it's great, and we've been in again with the Food Summit and other things, quite busy. So here's the briefing, and then after the briefing, I want to have as much conversation as possible. Yeah, I think if you're in Britain, or indeed in parts of the US, you might be thinking, well, COVID, it's going. And perhaps it is, but I'm just not sure. And so I need to share with you reasons for my uncertainty. And I also need to share with you the issues around the virus and the response that we think are highly relevant. So the epidemiology. Well, the total numbers have been coming down actually for the last 2 months, and week on week they've been reducing, not super fast. It's been a kind of slow reduction, and we're still working with at least 400,000 new confirmed cases a day, and perhaps around 3.5 million a week, but it has really reduced quite a lot. So I've been looking at the total figures, and there really are 5 periods when the numbers seem to be peaking. In May in March, April, May last year, that was the sort of first peak when really it was quite alarming to watch it all happening. Now it's tiny compared with what we've seen subsequently. And then we moved into quite a lot of COVID around in the late summer last year in the Northern Hemisphere. That was August, September. We had another high peak in December last year, and then it went up again in March, April this year, and it then was particularly high in September this year. And I was trying to say to myself, can I explain why there's been these peaks? And the answer is actually what you see when you look at the world figures is that when there's a different peak, actually the numbers are going up in different places. So, for example, the peak that occurred about 2 months ago was really strongly influenced by the very large number of cases being reported in Japan. The peak that occurred in April, May this year was influenced by the very large number of cases in India and other countries in the region. And then the peak that occurred at the end of last year was hugely influenced by the large number of cases in the United Kingdom. The earlier peaks influenced by the large number of cases in the United States and then in Europe. And so I've concluded that the global figures mask an awful lot of what's happening locally. And so together with our team, we've been trying to look around the world in order to be able to explain to you and to each other what's actually happening. There are very localized surges of disease occurring often in places which are very narrowly defined in terms of geographical radius. And during the last few weeks, the parts of the world that really have been reporting an awful lot of COVID, Russia, Eastern Europe, Caribbean islands, some Asian countries, for example, Papua New Guinea, some places in Africa like Democratic Republic of Congo. And there's not actually a very precise pattern to it. You just get these surges and they crop up. Usually in the surges, there's a small number of people who seem to be very infectious, and they are responsible for spreading the virus. And the surges seem to be most likely to occur in places where there's previously been quite a lot of the virus detected. And so what we believe is that if you've had a lot of virus in a community, then 2 months later, after the numbers have gone down, it's pretty likely that that same community is going to show a surge coming again. And that implies to us that keeping the numbers down, particularly when an outbreak is starting, can be incredibly helpful for reducing the risk of a further surge 2 months later. That in turn leads me and colleagues to say, please continue being careful. Do not assume that you can just be comfortable letting the virus infect large numbers of people in your society, because that's not, certainly may not be a problem for now if you've decided that that's something you're prepared to do, but the virus will surge back again after 2 months if there's been a lot of spread. Now, who's not worried about a lot of virus spread in their communities? Well, there's a very small number of countries that have concluded that because they can reduce severe disease and death through immunization, they can also afford to relax on personal protection, even relax on public health, and rely on vaccines to keep morbidity and mortality down, to keep the economy going. But what they have to understand is they're still going to have an awful lot of virus being transmitted. Firstly, they're going to have virus being transmitted among vaccinated people, because it still spreads even among people who are vaccinated. Secondly, they're going to have a lot of virus spreading among unvaccinated people. And that will include people who've decided they don't want to be vaccinated and people who've not yet been reached with the vaccine. Now, if there are a lot of people who don't want to be vaccinated, that of course creates a large pool of people who are susceptible. And if they've also not been infected before, they've not had asymptomatic infection, then they could easily become a community within which further surges will occur. So my colleagues in the WHO Secretariat are telling me that what they're seeing in Russia, what they're seeing in Eastern Europe, and what they're seeing in many of the other places where we're witnessing surges is outbreaks among unvaccinated people, either because they've not been reached with the vaccine, as I said, or because they don't want to be vaccinated. And that in turn means that we're going to go on seeing spikes and surges of disease and death as long as there are a lot of people who are susceptible because they're not vaccinated. My friends in the business community say, well, if that's what's happening, we ought to be moving towards compulsory vaccination requirements in our businesses. People working in hospitality, in airlines, and in a number of jobs where workers seem to be essential, like the meat processing sector and so on. They're moving towards what's generally called vaccine mandates. You need to be vaccinated if you're going to keep your job here. Now, my line on this, just in case it's of interest, is that it's perfectly reasonable for an employer to discuss with employees specific forms of behavior that the employer would like the employees to adopt. But it's got to be an open discussion. And the employee representatives may decide that in return for shifting to different forms of behavior, different ways of behaving in their social lives, or the need to be immunized, they want to see certain additional concessions in the industrial sector in which they work. For example, more paid sick pay, or better living and working conditions in the form of uniform or protection against disease or health and safety issues. And I think that there is a very definite shift to a great deal of incorporation of COVID-related issues into the health and safety negotiation between unions and workers in a number of key sectors. And I think this is, personally, I think this is desirable. I think it should be okay for an employer to discuss this with the employees. And if the employees and the employer can reach an agreement on what extra incentives there should be from the employer, I think that's a good thing. And I also think it's a good thing if this discussion is associated with the options for improving representation by unions. For example, the meat cutting sector, these people who work in these often highly automated plants to dissect dead animals and to turn them into the things that one can buy in supermarkets. A lot of these people working in these situations have quite precarious contracts and quite difficult issues around, for example, what happens if they get sick and need to stay at home. And my colleagues in the unions who are union federations that are representing such people are telling me that there is actually quite an interesting opportunity for renegotiating working conditions. This is now part of a bigger issue that's been ignited by COVID, but it's really telling us something that's been going on for a very long time. That's been identified in the UK newspaper, The Guardian, written a lot by a very talented reporter called Felicity Lawrence. She has been writing about the emergence of an underclass of employment in Western Europe and in other so-called advanced countries, of people who are often recruited in gangs and moved across quite large distances and brought to other places to work as gangs of laborers, for example, in meat processing or vegetable processing or fish processing or sandwich making and other related jobs in order to provide labor. And of course, in countries, for example, like Britain, that have recently left the European Union with the opportunities for movement of labor, the sudden lack of people who were prepared to do difficult jobs for low wages has led to all sorts of knock-on effects. But it's not just people working in food. We happen to have seen a lot of the food stuff because of our work on food workers and COVID. But of course, as people in Britain know, this applies to a lot of other jobs, including even people who drive large vehicles. This is interesting, isn't it? It's actually a revelation from COVID, and it's feeding through to a recognition by a lot of employers and indeed governments that there are challenges in the way in which labor is being used, particularly challenges in this effort by certain groups of employers to be able to run industries based on using the labor of people who are trucked in from outside and who are paid super low wages or have to work under super challenging conditions, often living in overcrowded accommodation. And we came into discovering this and working on it with the International Union of Food Workers because of our interest in links between food and COVID. So I just wanted to say that, and I wanted to really dig into this, that more and more we are seeing knock-on impacts of COVID going into different sectors, revealing quite serious structural problems in the conditions under which people work or the conditions under which people live, that in turn are no longer being tolerated by groups of workers, and that is leading to some options for re-examination. Of course, in the UK, those of you who study politics will have seen that this led to some interesting statements in the conference of the current ruling party, the Conservative Party, who have described where they're going to go to on things like labour relations in quite surprising terms, and it's causing a bit of interaction in the media in the UK. Watch this space, it's going to go on. I want to continue with some snippets based on what's going on. I want to finish by talking about vaccines. So what I wanted to say to you today is that COVID is revealing inequities everywhere. We saw it massively through the food summit at the end of September, but we're seeing it in the tourism industry. We're seeing it in a lot of other sectors that many of you are familiar with. And most governments are realizing they can't just sweep this under the carpet. And in fact, they're having to take it seriously, but it's leading to a rethink about the structure of labor and the structure of society. One of the things that's come out also is that poor people are doing really badly as a result of COVID, and this is often not picked up. And it requires a combination of good journalism and good social science research in order to uncover it. And the findings about what's happening to very poor people tend to come out later than the findings about what happens to the more general population. So those of you who are keeping a close eye on inequity, I'd be really interested to know whether you're picking this up as well, where you are. But Katherine and I really have been focusing on it. We are looking for it now. We think that it's also having a huge influence on migratory pressures as well. I'd now like to just go to a number of the other knock-on impacts of what's happening. I think anybody who is in the UK or in the US, and to a degree in France, is super conscious that actually COVID is causing major stresses in health systems, and those stresses are being demonstrated by much more than full intensive care units. Now it is huge delays in access to referral services for people who've got chronic illness, like diabetes, like different forms of cancer. It's huge delays in access to referral services for people who've got conditions that are non-fatal, but are still deeply uncomfortable, like orthopedic referrals because of some problem in a joint or some problem at the feet. And we have a colleague who is in physiotherapy, who's just saying the system is just not working. But it's not working, it's not just one or two places in the UK or in the rest of Europe or in Ireland or in Canada. No, this is widespread. And then the people who are the primary contact physicians, the general practitioners or the practice nurses, are actually feeling quite stressed and burned. And they feel being asked to go on and on and on, finding that extra bit and working under really difficult circumstances, and just beginning to say, no, I just can't do it. It just makes me feel too rotten. And then you get into a nasty little vicious cycle between the bosses, be they politicians or others, and the workers, where the bosses start saying in public that the family doctors are being lazy. No, it's not that. And everybody, we've got to get better language for describing it. When a health service is being overwhelmed, there's not a sort of light that goes up in the entrance to the hospital saying overwhelmed. There may be a light saying long waiting times for accident and emergency, but that's the tip of the iceberg. What really is happening is you've got absenteeism by staff. You've got people really fed up that they're being asked to get vaccinated if they want to keep their jobs in certain countries. You've got people just saying, I just can't be bothered to do the extra hours because I get so much abuse. And abuse in the health service workplace is happening in general practice, is happening in hospitals. And then there's that other rather bizarre thing of government saying we love our health workers, they're angels, or they're the male equivalent, assuming angel is a gendered word. But at the same time, they get pay rises less than inflation. And inflation is happening now. It's just picking up. It's slow. We're at the early stages of really galloping inflation, but it's already affecting what people can eat, and especially in Britain, because there's just been a cut to the universal credit. So I just want to stress to you that we're coming into a tough time, and it's not the people who are like me and you who've got nice jobs and security. It's the people on daily wages, and it's the people who are doing a bit extra to try to just get a bit for their families. And then they get stressed, and then the violence starts or gets worse, and then the kids get really fed up and stay out, and all sorts of other bad stuff goes on. And that is linked, and it's happening. I just wanted to give you some examples. Iran. Did you know that in Iran, thousands of doctors are trying to leave the country because they just can't stand the stress. They can't stand the strain. They can't stand the assaults. Often they're not paid. And the hospitals are overcrowded, and they can't provide a decent service. Singapore, same story. Australia, same story. Parts of Italy, the same. And then we go to countries where they're actually still trying to deal with the problem. Thailand, Lao PDR, and so on. Big numbers, field hospitals being put up in Vientiane, trying to find ways to continue to see patients with other conditions while dealing with COVID. Big anxiety in Nepal. The numbers came down beautifully in Nepal, but there's been a lot of virus. And they're really worried that in the festivals that are happening around now, it'll go up again. I told you about Eastern Europe. Romania, country that I know quite well, where my son went to hospital, and there again, numbers are high, Romania and Bulgaria. And so what I want to just stress to you is this pattern of spikes and surges has huge, bad local effects. I think I want to talk a little bit about vaccination. I mean, more and more, I am aware of just how amazing the current vaccines are, with their relatively high protective efficacy, and it seems reasonable duration. But what is the use of vaccines? What should it be used for? Answer: to stop people from getting sick and dying. And they should primarily be for older people, people with diabetes, people with heart disease, people with disability, people who've got respiratory insufficiency. They are to save life, to protect life. These vaccines have not been licensed for widespread administration, for use in children. They've not been licensed for use to end the pandemic. The way you reduce the impact of the pandemic is you vaccinate to shield the people at risk, and at the same time you maintain public health to identify people with the disease and isolate them quickly. So you do that to stop the spikes, and the surges then won't develop. But you make sure that everybody does wear face masks, because we know that reduces transmission. When they're in public transport, when they're in crowded places, there is no point in having people not wearing face masks. It really does reduce the risk. So the only advantage of having people not wearing face masks is if you're a politician who believes that they'll get more votes by somehow stirring up the illusion that wearing face masks is some sort of sissy behavior that you shouldn't be doing. That's the only reason why people are asking for non-wearing of face masks, because all the public health evidence more and more says this is the right thing to do. And they're saying wear the surgical masks. And then lastly, last point is to say, unless we can get vaccine equity, unless we can get poorer countries being able to vaccinate their people so they can prevent death among those at risk, we are sowing the seeds of long-term, real mistrust and anger between countries that you're close to and working in, like Uganda, where Marianne has got this amazing contact with the head of the medical stores, are basically telling us to ask us to run immunization campaigns on the basis of odd donations of near to expire vaccines that we never know about in advance, and to tell us that that's the way we ought to organize our vaccination programs. It's just totally disrespectful. And I think for many people, it's at the edge of what they can accept. And they won't forget this. African leaders, African professionals won't forget this, nor those in the Middle East, nor those in Asia, nor those in Latin America. And yes, they're doing workarounds and they're trying to go to the companies and they're paying extra money trying to get vaccines quickly because COVAX has been under-resourced, but it's wrong. So we continue, myself and others, just trying to get the rich countries to just defer their deliveries by 2 months and to stop stockpiling more and more vaccines against the possibility that they'll get variants, that it should be going into arms of people in developing countries. And to try to get world leaders who are coming to a climate conference in Glasgow on the beginning of November to just say, come on, let's work together on COVID by just deferring delivery a bit and then organizing proper supplies to developing countries rather than scraps here and scraps there of mixed up vaccines that are not according to any proper administration schedule. And let's show the world that we can do something together. We're asking the world to do climate at the beginning of November in Glasgow. Well, why not kick it off by sorting out flu and sorting out COVID, and do that by getting the vaccines to where they need to be. And it's about a month to 6 weeks supply needs to go into COVAX. And then we can get to the 10% of the world immunized by September. Well, we missed that. And the 40% of the world immunized by the end of the year. So those are my opening remarks. Over to Katherine, it was, for just talking a little bit about our illustration, and then we will go around and get comments and questions. Okay.
Hi, Camille, do you have a chance to show us your illustration? We'd love to see it.
Hi, sorry. Yeah.
Oh, super. Is it possible? I'm not sure I can do it from my, yes, fantastic. Thank you so much. I am particularly fond always of the drawing of the virus. Do you have anything you want to speak to in this that particularly resonates with you?
Yeah, I guess so, especially because I'm based in the UK, even though I'm French. Yeah, just reiterating that COVID reveals inequities, and you know, even if leaders in the UK especially say COVID is going, well, it's revealing a lot of things that are structurally dysfunctional. So yeah, and it's not going anyway. So.
No, right. I think we have all had to become familiar with that particular reality, indeed. Well, thank you so much, David. We've had a number of fantastic comments. I am in the process of sending you a couple of WhatsApps, but in the meantime, I think Rebecca has joined us, and which is fantastic. And Rebecca is speaking about businesses and how we should treat them. Annie has some really very distressing news about the local Essex MP, which maybe she can share with us, but I don't want to spoil everybody's interventions. Maybe I hand it back to you, David, and you take us away.
Okay, great. So we go quick. I want everybody to just come in, make some comments, help us to make sense of what's going on. And just want, Vicki, would you be prepared also to say a word or two about how you're getting on with your own particular work of public health coming to people and the collaboration? So if we went, Rebecca, Annie, was that Annie you said is the second? I'm sorry, I missed it, Catherine, but I think it was Annie for the Essex MP. Yeah, it was.
Yeah,
So
indeed.
Rebecca, Annie, Vicki, and then I'm very keen to hear also from people who've come in from a long way away. So just to make sure that I know we really want to hear your experiences from where you are around the world and any quick comments. By the way, it's lovely to see Farhang. I didn't see you there at the beginning when you joined. Lovely that you're with us. Brilliant, brilliant, brilliant. Okay, Rebecca, please.
Yeah. Firstly, I don't know if we've been trying to make sense of this since March 2020. And I feel like every time we go in the same circle. So maybe we get a little bit closer each time. I don't know. But just hearing you talk about all the businesses, David, I agree, but just from a public health perspective, I don't think we can treat all businesses equally. The healthcare industry, unfortunately, is privatized in many parts of the world. Even here in Chile, where there is a public health system, there's also a private health system. And if those businesses are treated just like any other business where it's sort of voluntary what they can mandate, I don't think that's fair to the public and public health that health workers can continue to have these workarounds around the vaccine, even if they're saying they're constantly getting tested. Same with the prison industry, at least in the US, the prison industry is an industry, it's all private businesses. So again, like I think that those, in my mind, are some of the top two sort of industries within the private sector where vaccines have to be mandated. I think it's a disservice to the public and public health to say that all businesses are sort of on the same plane when I don't think they are in this case. And then I'll just add my second thing that I always put in the chat. There's more livelihoods lost in this world because of COVID than COVID positive people. And we're still not fully capturing the cumulative effect of that. And again, like even if COVID-19 stays endemic but sort of goes down, the cumulative effect of livelihoods lost globally is still going to outweigh the number of positive cases. That's just how the curve is.
Yeah. And thank you for saying that, Rebecca. I have to tune into your second point. What that means to me is that humanity has to learn to deal with this virus without somehow locking down societies as the first instinctive response. It's a wrong response. And we learned that painfully, as I've told you on several occasions before, when we were involved, Catherine and I, in Ebola in West Africa. It's never to be done through force, through disincentives, through even use of violence. It has to be done through joint action, partnering, and really sharing the responsibility. And governments that are using disincentives and force and other things as the mainstay of their COVID response and are saying, you know, you should go into lockdown early, otherwise you're not real. All that talk, it's so dangerous. Unfortunately, it's the common narrative in many governments, including the UK, including perhaps some south of the hemisphere. It's the wrong narrative. And so I was very much trying to make sense of a report that's been produced by the All-Party Parliamentary Committee on Coronavirus in the UK, chaired by a former health secretary called Jeremy Hunt. And there's a little bit of a narrative there that says, well, the big mistake was that they waited till March 2020, mid or late, to go into lockdown. Well, I mean, the bigger mistake might be that the system for detecting cases and isolating them was rather strangely designed because it wasn't done locally. It was done from call centres miles away by people who hadn't got a clue what they were doing. And they didn't think about, when designing this, what incentives you need to get people to isolate at home, especially if they don't get sick pay or if the sick pay is too low. So those sorts of issues about how people really live did not appear to be brought into the design, but that didn't seem to be perhaps the main issue. However, it's a pretty comprehensive critique of that, and what I've tried to do on that one is to do everything I can not to be involved in exchanges that are just designed to fault the British government for the timing of when they went into lockdown or fault their advisors, because I don't think that's the issue. I think the mindset behind it might have been wrong, and that's what I want to go on working on. And I feel, I mean, I'm getting somewhere, but still it's a long, long journey to get the public, the centrality of public health in organizing these things onto the discussion table. And we've got to do it because the virus isn't going away, and these surges are going to go on coming, and we're going to have to continue to make the point that dealing with the surge early, these two words, rapidly and robustly, is the key to getting ahead of it. Thank you very much indeed, Rebecca. Let me go to Annie, please.
David, can I first say that I think you captured the situation in the UK brilliantly, so I'm just agreeing with it. I'm not going to repeat it. What I wanted to spend my couple of seconds on was the earlier posts I put up about developing local leadership, because I started off thinking as a social developer, how the hell are we going to do that? But actually, I think we're making really good progress here. We've just had a really successful conference on Build Back Fairer, which is getting local organisations, health, social sector, the NGOs working together better. And there's real results coming out of that, both in terms of healthcare and in terms of better using resources. And so we had 250 people on the call, which, you know, for a small area of Essex, that was fantastic. So I'm really pleased with that. And we're really learning from somebody called Michael Marmot, who I'm sure you know. He's absolutely brilliant. He just tells us health inequality is so bad here, we should be ashamed of ourselves. So my part was banging on about power, which you've heard me bang on about before. And so
yeah, but good that you do it.
It's encouraging. What's really interesting is we're pushing the boundaries, but in this really centralised government in England, we don't know how far we can push the boundaries before somebody says, okay, that's enough, you're not going to do that. And so there is a sort of a test going on, but I think we're encouraged working together, and I'm much more optimistic about that, which I think is a response to some of the things that Rebecca was saying about going round and round. Yes, you do go round and round. I mean, you must feel, David, after all the work you've done on Ebola, that you're going round and round. And that, you know, as a social developer, I just think, yeah, round and round. And you just have to stay on the roundabout. And then really quickly about the MP. God, that's the second MP we've had murdered. And I just stuck that in because of what you were saying about the tensions in society. Yeah. And we haven't, it was only done, he poor bloke, who was, it only happened, David Amis, it only happened lunchtime-ish, I think. So we don't know much about that yet, but it just shows it's this sort of inequity, the inequalities which are leading to these terrible clashes sometimes, and it is shocking. But so I've started off being positive and thanking you for what you're saying about the UK, and I'm ending on this sort of a bit of a danger point, because, you know, certainly with the people that go out canvassing in our various groups, particularly with the women, we've got to think about, are they still okay going out on their own, you know, which takes us into the sort of women and violence debate which is going on, and you can see how it's all much for peace. And I think my last sentence is, COVID's not an outlier, it's just like the rest of society. Thanks, everybody.
First of all, thank you, Annie, for who you are and how you are. Secondly, I was super upset to read of another MP stabbed in constituency surgery? Because that's going to make it so difficult. Do you remember how all the kind of terrorist attacks suddenly made it so much harder to go into public buildings?
That's right.
Need
Yes.
for security and so on, which meant that public buildings essentially found it harder to provide a public service. So obviously with MPs being killed, like Joe, who got killed before, and now him, it is just, it disturbs me. I mean, so I'm sad about the guy being killed, but I'm sad about what it means for society. I want John to react to what you just said, if you don't mind. John, please.
Hi, David. So I was starting thinking around employment and its impact on health. And I think it's much more complex than we've said so far. Lots of people working in logistics, for example, are employed offshore, so they can't even have a negotiation with their employers because in some cases they don't even know who they are. We've seen the impact of health systems, the strain that people are under, and the long periods of strain. But we could have had this conversation about food and COVID, how people whose diets are worse and who may be obese are suffering disproportionately. And we could have had this conversation about housing and COVID. So when Annie talks about Marmot and the wider indicators of health, it's a really important conversation. And the real challenge is, how do we have it's the repeated reluctance, if you like, to engage in a conversation that brings these factors in, a comfort almost, or a feeling that from political leadership that it's safer to keep talking about symptoms rather than really getting to root cause. And it needs leaders who are prepared to open up the conversation, who are prepared to take the risk of going into a space that they don't know the answer to and don't know how people are going to respond to it, which is a systems leadership issue. And that's why also the news from the UK today, this lunchtime, is so sad, so saddening, not just for the individual and their family, but just how it closes down our spaces and people's confidence and courage to really open up the conversations that we need to have.
John, thank you always for your ability to help us look at these issues through different perspectives, and for your systems leadership. I want to invite Vicki and then Jonathan Fitzsimon, and hopefully we get in at least 2 other people. Don't hesitate to flag to Katherine, because I'm not looking at my chat. Please but put in the chat. She's looking at the chat. She'll send it to me. And if I don't see it, she'll shout. Okay, Vicki, please. Lovely to see you.
Yeah, great to be here, because I missed the last one. Yeah, just a couple of things, I suppose. Nazim's in Liverpool at the moment, and I would say he's been hitting Liverpool like a tropical storm, playing in all kinds of venues, from community places and Toxteth, where, yeah, for those of you who know Liverpool, or those who don't, it's an area of great deprivation where a lot of the Black and ethnic minorities live. And he's been in conversation with people there, talking about how things have been done in Gambia, what's going on here. He's been in schools, because it's also Black History Month, talking to them, and also even at the Cavern, so where the home of the Beatles. So he's been sort of all over the place, shaking things up a bit. We've been talking to public health as well. And I think, actually, Annie, one of the things you were talking about, I think one of the more exciting things, because we're also seeing in Liverpool huge inequalities in vaccine uptake between some of the most deprived areas and some of the richer areas. And I think the local government is now, they've tried so many methods and they're getting a bit fatigued, but we're seeing new partnerships now forming. And what I'm finding quite exciting is that they're now talking to the Liverpool School of Tropical Medicine, saying, well, what can we learn from Africa? What methods can we use there to try and really get community engagement? We're also seeing them working with artist collectives. So yeah, although it's not all good news, I like the fact that we're getting these new collaborations now, trying to find different ways of doing things. And I'm very much hoping that, Nazim, as the public health director, is very aware that Nazim's here in the UK. So I'm trying to get him involved in this as well, and look at what can we learn from Africa, what can we learn from musicians, and how can we really build local approaches. So I think that's all I need to say at this point, David.
Wow. And you know, all this is part of a phenomenon that Anya's just described, you've just described it, Vicki, and Rebecca's seeing it in where she is, the phenomenon of new connections being made, new energy going into relationships, because people are looking for different ways that might work better. And then new forms of collaboration emerging. And I don't think we need to say, is any one of these going to become the new thing, sort of as big as the cell phone? No, it will be a lot of relatively small shifts, but when added together, it's huge. That's at least my view of how the emergent form of novel systems leadership is going to become something that's part of our lives. And you can say, well, will it be enough to cope with all the other badness that's going on around the place? Well, it won't be like that, because there'll be badness things like unfortunately today's murder, and there will be goodness things, and they will all be coming up, and they will change the balance. But it will take some time before new ways of working become dominant, and there may be a lot of struggles before we get there, even a lot worse than what we got now. Vicki, thank you for the way you do this, and through you, thanks to Nazim for the way he does it, and this notion that we've got a lot to learn from Africa. Yes, we have. A collaboration between African nations on COVID-19 is quite extraordinary, and the energy in Africa going into vaccine manufacture and vaccine filling and finishing locally is huge. Lovely. And I thought I'd now go to Jonathan, please. Jonathan.
Thanks, David. I'm really glad to be back. I've missed the last several meetings, so it's nice to be back. And thank you, Vicki, for taking me on a little trip down memory lane. Then I grew up to Liverpool, so that was nice. But I now live and work in Canada, and so I wanted to follow up on David's comments about the healthcare system and the impact of COVID. And I recognize that I'm doing that from a wealthy country with a publicly funded healthcare system. Not perfect, but it is a publicly funded healthcare system, which is far more than many, many other countries around the world have. But I was really taken by that point you were raising about the future impact that COVID is having on other health issues. So this delay that is building up now on other things that have had to be put on hold because of COVID is creating this huge backlog. And then it ties in with what you were talking about, the workers, and I particularly sort of think of healthcare workers at every level, from personal support workers through all nursing grades and physicians and everyone connected with healthcare. Is that it's the same people who have been working at emergency levels for the last 18 months. Who are the people who are supposed to somehow deal with this backlog over the next 18 months, 3 years, 5 years, 10 years. And yet we see this sort of variance from, like you say, people on one hand calling them angels, and yet what we see in parts of Ontario where I am, actual demonstrations outside of hospitals, people demonstrating against the very workers that are helping the people infected with COVID inside. It's as somehow being the cause of the restrictions on their lifestyle and the restrictions, the rules about them having to be vaccinated. So I worry for the healthcare system in a wealthy nation with a publicly funded healthcare system, that the people who deliver it are just going to feel the strain more and more. And that's going to become more obvious in the years to come where we try to deal with the backlog.
Jonathan, it looks like you're in your own consulting rooms, perhaps in a surgery somewhere. Are you a GP in Canada, or what are you doing these days?
Yeah, I'm a family doc. I also work in the hospital, but mostly for the last 18 months, I've been running our COVID assessment centre for Renfrew County, which is the largest county in Ontario.
Wow.
So a mixed thing. And I picked up on what you were saying about little different small system changes. Yeah. We've been trying to introduce more virtual options to allow equity to rural, remote, underserviced, Indigenous communities, of which there are a lot in the area where I live. And I agree, it's these little subtle changes that are actually going to make the difference, but there has to be the political will to support the people who can do that.
Jonathan, thank you so much, particularly for the way you rounded it up to the end, which speaking as somebody, you're speaking as somebody who really is doing it. And don't imagine that things in advanced countries necessarily are so much better than they are in poorer countries, that the comparisons are perhaps unhelpful. Actually, I want to absolutely stress to you that advanced countries rethinking and relearning the basis of community healthcare may well be one of the most important transformations that we're going to see in trying to find the patterns of healthcare that are needed for the future. Thank you, Jonathan, very much indeed. Just to say, John Atkinson is putting a lot of material in the chat on the Michael Marmot work. Michael Marmot, I know because he and I used to be contemporaries, and he wrote a lot of work on social determinants of health, which has had a massive impact on some of us working in public health, just pointing out that being poor makes you much, much, much more likely to be sick, something that Vicki doesn't need to read about because she sees it, and something that I suspect most people here on this call are super aware of, but it was important that somebody codified it. Thank you very much indeed, Michael. I wanted just to now just see whether anybody else would like to come in quickly to make any last remarks before we close. And to help me do that, Katherine, is there anybody you would like to say, because you're tracking things, that you would like us to bring in?
Well, you know, Lynn just asked about your comments some time ago on COVID increasing civil unrest, and you and I have been watching this, and it certainly is coming up. I wonder if you had any sort of closing thoughts on how you feel like the ongoing fatigue and displeasure and everything else might be affecting people.
And Katherine, also don't hesitate to give your own assessment of this, because I know this is something you've been looking at. But Chime, did you have a hand up saying you wanted to come in and say a word or not?
Yes, I just wanted, it was earlier in the conversation, we went far more, so I have many points. So quickly, just in Israel, the situation is much better, but the important thing to see is that over 60s unvaccinated are mostly the sick people. All the others are almost not coming to hospital at all, and there are only very few cases under 60, like less than 0.3% young vaccinated people arrive to hospital. It's mainly over 60 unvaccinated. I wanted to say about the passport system is used here. So if you want to go to a public place, you have a green passport if you're vaccinated. And if you work in a place, they just ask you to test. If you don't want to be vaccinated, you need to show a test daily. It's not
daily.
Daily test.
And do you have to pay for the tests out of your pocket, or does the
No, you get like a small pack like in the UK, and you can just do the test, and all students are having to test as well.
So these are lateral flow antigen tests.
Even if something is wrong, then you go and do another test. And if a child is sick in a class, the whole class is checking, and if anybody is not well, he's got to go home, and the rest are staying. This is a change they've done. It was not like this before.
Right.
I just want to say something else, going back to the food. Just a quick. It was. I want to say that the problem with food is there is another issue, that everybody is eating processed food, and I think it's one of the changes that can happen is that people can do more of their own food and buying just basic vegetables and products and do their own food. So less processed people and healthier as well, I think.
Thank you for that, Chime. We'll try and do a bit more on food. NK Sethi, would you like to just have the last word? It's only the reason why I'm coming to you, NK, is I've been very aware of health workers under attack in different places in India, and I just wanted any comments on that you might want to make.
Well, Dr. David, that's been happening, but efforts are being made to control it. That's one. I'll like to go a little beyond India. Well, India is making efforts to vaccinate greater population, and with the forthcoming festival season, efforts are being made so that the spreads does not spread the way it had been last year. Now, coming over to the global scenario, my concern is a little about how, on one hand, we have 2 to 3% of the population vaccinated in low-income countries, 1 dose. On the other hand, the world is going in for boosters and it's going in for immunization for children. COVAX is existing. How do we allocate and make more doses? My issue is how to change the situation from rhetoric to reality. I've not been able to get any answer. 1. Second, about travel related guidelines or a matrix. Different countries are adopting different policies. Getting COVID test done, vaccination, no quarantine. It's a bizarre, I would say it's a different situation altogether. Is some agency working on making a matrix? That is another issue which has come to my mind. Well, I would not take more of your time, but I've raised issues which have come to my mind. Thank you so much.
But I love it that you send your questions to me. I took your concern about different rules for vaccine and travel from different countries to the person, I think I won't mention the person's name, at the World Health Organization who knows about this. And this person replied, "We recognize the mess for travel right now, which is based on country-specific requirements and different recognition of regimes by countries. WHO is very clear that there shouldn't be vaccine requirements imposed on travel, but countries have decided otherwise, creating an extraordinarily confusing and complex situations, resulting in immunizations being used where they're not needed and people being extremely confused. We are pressing nations to sort this out and to recognize that the WHO emergency use license product should be recognized everywhere, and trying to get harmonization of schedules, but we're not yet in a position to do this. We've still got many Canadians not able to go to the US because they got AstraZeneca, followed by one of the mRNA recognized vaccines. I don't know how quickly this will sort out. This is the WHO responsible person, but I think we will get there eventually. So our job as global citizens is to say to governments, you've got to sort this out. And the only way you sort these things out is by leaning forward and collaborating and doing it. So NK, I'll work with you on that. Thank you very much, everybody, for joining us. We now go to Katherine to close us, and Miriam for any last words.
Well, from my end, thanks so much. I think we've ended on the note that we should end on, which is an expert from WHO telling us that there is hope that the travel situation will resolve itself at some point. But in the meantime, it is indeed a confusing pastiche that we are all having to navigate as we try to get places. But for me, thanks very much. Camille, do you want to show us your picture quickly at the end here? I say picture, I should say illustration. That was quite rude.
Yeah, no, it's okay. It's a picture. Can you see it?
Yes. Oh, I love that you put like right up there, we have a lot to learn from Africa. That is fantastic.
Yeah, I think it's the sentence that resonated the most in
I also love that COVID is moved in and is in the bathtub. I'm gonna cut that out and put that as my new WhatsApp.
He's overstaying his welcome.
It's fantastic. Thank you so much. For me, this is great. Is there anything you wanted to comment on other than that? I've picked 2 things out, but
No, sorry, I was on mute. No, yeah, just on a little cartoon about COVID taking baths. It's just, I know it's all quite emotional and always scary narrative. So it's just a way of, I don't know, making something funny about COVID. But yeah.
No, and you need it, and it's the way we get messages across. People, pictures are worth 1,000 words, I think is not inaccurate. And I think that's it from me. It's Friday afternoon. I'll hand over to Miriam, who